Good evening, everyone. Hi, welcome for the fifth webinar of the MU-JSU NCD's Research Collaborative Center. I'm Rungnapha Rushop. I'm delighted to be a moderator for today's event. And today we have three speakers whose expertise in sexual health in patients with non-communicable diseases. Now I'd like to introduce three speakers. And the first speaker, he's here with us already. The first speaker is Associate Professor Dr. Caleb Ferguson. From School of Nursing, University of Wollongong, Australia, Dr. Ferguson focuses on individuals with cardiovascular disease and stroke. He has received many research funding and awards related to cardiovascular disease, and he will be talking about sexual health after stroke for today's webinar. The second speaker is Associate Professor Dr. Usawadi Asadon Viset. She is the faculty member of the Department of Surgical Nursing, Mahidol University. Her research focuses on transitional care and telehealth in post-operative patients. Her topic for today is sexual health in surgical patients. And the last speaker is Dr. John Rihari Thomas from School of Nursing, University of Wollongong, Australia. Dr. Rihari Thomas has held many IN roles in both cardiology and setting up and managing medical emergency teams. Also, he has been involved in developing and implementing large multi-site research trials, as well as supporting nurses to improve their nursing practice. His topic for today is approaching the difficult conversation. If you have any questions, please type in the chat box, and I will ask the questions at the end of their presentations. Now, I'd like to ask Dr. Ferguson to start the presentation, please.
Thank you, and I'll just share my screen. Is that projecting okay?
Yeah, it looks good now.
Perfect. Thank you. Thank you so much. Thank you so much for the opportunity to speak with you this evening. I've just recently joined the University of Wollongong, and it's great to be with the university and with you this evening. And thank you for the invitation to come and share with you an overview, really, and talking about sexuality and sexual health after stroke. And as mentioned in the introduction, my clinical background is working in acute stroke units, and this is something that's often not very well addressed. So I'm glad that we are addressing the topic this evening too. Perfect. So I thought I would provide just a short background in relation to stroke. And a lot of these statistics are related to the global risk of stroke and the prevalence and the burden that stroke presents with a worldwide perspective. But really to begin, acknowledging that stroke is often a very sudden and onset event, and this is a life-changing event for many, and it often with devastating consequences. Death is common, and the individual or stroke survivor often will go through a long period of rehabilitation and may require a lot of support after that stroke event. Stroke remains the second leading cause of death worldwide, and the third leading cause of disability as well. And stroke really doesn't just affect the individual person, but also their caregiver, their family network and community, and the broader society in relation to socioeconomic cost. And you can see there the estimated cost in US dollars coming in at 271 billion. There's been some really good epidemiological studies looking at the global lifetime risk of stroke, and that's estimated to be 1 in 4 individuals. But it's not all doom and gloom in respect to stroke prevention, in that stroke is a highly preventable non-communicable disease. There are a lot of cardiovascular risk factors associated with stroke, and we estimate that around about 80% of all strokes are preventable. And obviously age and advanced age is a major risk factor for stroke, but also other cardiovascular risk factors such as hypertension, but also diabetes and other chronic cardiovascular diseases as well. Many people think that stroke only affects older adults, but approximately 1/3 of stroke survivors are aged under the age of 65. And this is really important when we start to talk really around sexual health and sex and sexuality as well. But importantly, 2/3 of stroke survivors will live with some level of cognitive or functional disability. So this is important when we're thinking about stroke survivorship and living with disability in the long term as well. So just a little refresh on what we're talking about when we're talking about stroke. There are two main types of stroke. And so on the left-hand side, we can see ischemic stroke, and this accounts for 85% of all strokes. And we also have the hemorrhagic type of stroke, which is accounts for about 15% of all strokes. Quite different in how the signs and symptoms present and how the individuals will present to hospital. Often with the ischemic type of stroke, this is caused when there's a blockage in one of the major blood vessels within the brain, starving the brain tissue of oxygenated blood supply and causing there to be cell death in that area of the brain that's affected. And the severity of stroke often depends on the area of brain affected, but also a range of other factors in terms of how well the person was and disease-free prior to their stroke event, but a whole range of other factors go into prognosis after stroke as well. So risk factors for the ischemic type of stroke, as mentioned, around advanced age, but also hypertension is a major risk factor, but also things like heart failure and atrial fibrillation, but also diabetes and high cholesterol as well, playing major risk factors for ischemic stroke. Hemorrhagic stroke, as you can see in the picture on the right-hand side, hypertension is a key risk factor for the development of hemorrhagic stroke. Often with very high blood pressure, this leads to weakening of the vessel walls, and sometimes can be a bleed into that area of brain tissue as well. So quick refresher on the two main types. But I just wanted to really talk next around the impact of stroke and how stroke impacts individuals. And I think this is really a challenge in how we describe stroke. And because I think sometimes no two strokes are exactly the same, and stroke impacts individuals in very different ways. And that does depend on a number of factors, including the area of brain that's affected, but also another range of factors in terms of how well the person was before the event and other chronic conditions that they have as well in the context of multimorbidity. But I think it's really important for us to understand the underlying anatomy and pathophysiology, and looking at the different brain lobes and how that affects an individual as well. So when working in the stroke unit, I might encounter people who have had, for example, a stroke that just affects purely speech, and that could be speech articulation or the understanding of speech as well. And we have, the speech center within the brain, the two centers, the Broca's and the Wernicke's area within the brain, and they're responsible for speech articulation and speech reception as well. So really understanding which area of brain is affected, which vascular supplies, the vasculature that supplies that area of the brain is really important to understand as well. We see patients, I've given a few examples, and just wanted to acknowledge the images are from the Stroke Foundation here in Australia. But if someone has experienced a frontal lobe, these are some of the changes that we could expect. So things like personality, but also motor control, concentration in speaking for frontal lobe. And whereas with the parietal lobe and type of infarct, we're looking at things around feeling and sensation, such as touch, pain, cold or hot. And with the occipital lobe, we'd be concerned around things like vision. So we've got a few other examples here, and you can read these for yourself. But we're really interested in recognizing which area of the brain is affected and how that impacts the individual. And I think we need to really consider in rehabilitation and when considering sex and sexuality, the area of brain affected and how that impacts an individual surviving stroke as well. So I thought that I would highlight Maslow's hierarchy of needs in relation to particularly this domain that looks at love and belonging, and looking, the sentence underneath here is talking about friendship, about intimacy, family, and this sense of connection and belonging and adding to overall health and well-being. And I think it's really important for us to recognize that sex and sexuality is something that is an activity of daily living and contributes significantly to a person's mental health and emotional well-being and overall well-being and health of an individual as well. If you're more familiar with Roper, Logan and Tierney's model for activities of daily living, you'll recognize that expressing sexuality is one of those domains in the activities of daily living. And so it's really important that through our comprehensive nursing assessment that we assess sex and sexuality and then develop a care plan and implement nursing strategies and evaluate these strategies to adequately address a person's comprehensive care needs within both the acute stroke setting, but also in the rehabilitation setting and in the community environment as well when living at home too. So I wanted to provide a short overview just in relation to sex and stroke. And I guess sometimes people might view this as quite a taboo topic, and there has been some research. In Australia, we have a National Stroke Foundation audit, and they audit quite a lot of different things. But recently in some of the clinical audit data, it showed that sexuality is quite silenced in how this is addressed in the acute stroke and rehabilitation settings. And there's a huge gap in the care that we provide for patients with respect to sex and sexuality. And as I already previously mentioned, this an essential part of the human experience and really strongly associated with overall health and well-being and in relation to emotional and mental health as well. But importantly, I guess stroke can change an individual's way in which they feel about their body, but also how it works and how they feel about themselves and others, and also can affect the relationship with their partner. I think reflecting on some of my own clinical practice in the acute stroke unit, as I started this presentation, stroke is this sudden and onset and often life-changing event, which can be terribly distressing for the individual and for their loved ones and family members. And relationships really do change in those very acute stages. And as the person begins to live with stroke as well. Importantly, studies have not shown, so this is a bit of a myth buster, that sexual activity can trigger a stroke, and we'll come back to that just in a tick as well. And stroke survivors may need to adapt to a lot of their physical changes, so dealing with impairments after stroke, whether or not these are cognitive or functional impairments, and address some of the emotional changes that happen following a stroke, and talk with their partner and communicate with their partner and health professional with regards to sex as well. So in preparing for this talk today, I was interested in how sex after stroke is apologies, is experienced by stroke survivors and also their partners as well. And there's this really good systematic review that's conducted by some Australian colleagues, McGrath and colleagues, and also Emma Power, who is from UTS here in Sydney as well. And they were really interested to look at the experience of sexuality after stroke as reported by stroke survivors and their family members as well. And you can see in this table here that they've summarized the two themes that they've got here, and they've got some descriptive themes as well. And they describe this as, sexuality being silenced and sexuality it being muted and sometimes changed, but also not forgotten. And in some of these themes here, you can see that they add, in terms of their review, they've done a meta synthesis of the qualitative work that's written on sexuality and stroke. And they come up with these descriptive themes, and they talk about struggling to communicate within relationships. And this is really important with individuals that have aphasia after stroke, and whereby communication may be an issue as well. But also health professionals not talking about sexuality and not assessing it and not addressing it at all within their nursing care. And sexuality and disability being a taboo topic as well. And also these changes to pre-stroke relationships, and also these issues in relation to changed relationships with the stroke survivors' body, and in relation to impairment, but also resuming and the information around resuming sexual intimacy and adaptation and loss as well. You can see there's some quotes provided here, and I'm happy to provide a link through to this paper if anyone's really interested in this topic. I will share that paper for you to have a close read at after today's webinar as well, because I think it really provides some excellent areas in terms of how we can improve how we address these issues within acute care, but also rehabilitation too. So I wanted to next talk around how stroke can affect sex. And as I mentioned before, there's a bit of a myth buster in relation to sexual activity as a trigger for stroke. And studies have not shown that sexual activity can trigger a stroke. But there is often this fear when a person is past their very hyperacute stage of stroke and going home, really talking about resuming normal sexual activity, and this fear that exists in having sex. And I think this is in relation to that it could be a possible trigger for another stroke event. And I guess underpinning this is really in relation to often blood pressure changes, and it's whilst there is a very small incremental change to blood pressure sometimes, it's been shown that it's not a trigger for stroke as well. Other issues relate to physical changes, and I think these are often reported within the literature. It's quite considerable issues to address. And these can be things, thinking about how the body has changed after a stroke event. And some of these are quite sort of practical issues to think about. But engagement of an occupational therapist or a physiotherapist to assist with some of these issues can be very helpful. So these include things like physical changes, but also changes in muscle weakness and stiffness. Could be things around spasm in limbs, but also pain and different sensation, or fatigue or hormonal imbalances, but also issues related to incontinence. And I'll come back to incontinence later in the talk as well. Issues related to emotion and mood changes are really important to address. And these can be issues related to anger or irritability, sadness, and anxiety and depression are very common after stroke. And addressing these issues through both pharmacological and non-pharmacological interventions is particularly important. Anxiety and depression is very common after stroke, and I think addressing this within the acute care setting and at post-stroke follow-up is very, very important as well. But also, these emotions can really affect an individual or the stroke survivor's interest in participating in sex. And this can then impact on relationship issues and how they feel, how their partner feels about sex. And this can cause a lot of worry and concern and stress as well too. So my last point on this slide is really around sexual dysfunction. And I think it's important to understand that whilst stroke is not a direct cause of sexual dysfunction, it is, if an individual experiences any of these issues, such as maintaining an erection, vaginal lubrication, or reaching an orgasm, it could be in relation to other conditions, such as those related to cardiovascular disease or diabetes. And it's really important that we help address the underlying issues. And this could be as a cause of other multimorbid conditions, such as cardiovascular disease or diabetes, but also could be related to medication use, such as those medicines for hypertension or depression as well. So really making sure that the individual has a very good assessment, and that we help address these issues within the clinic as well is particularly important. So what are some things that can help? And I've provided just a few short points in thinking about how we can assist patients in being as sexually active as they would like to be. And I think it's really important for us to take a multidisciplinary approach in addressing sexuality and sex after stroke. And this might require engagement from other allied health disciplines, such as the occupational therapist, physiotherapist, or speech pathologist as well. And they can provide different advice, and this might be around positioning or helping practice into awkward positions. But also in Australia, we have specialist nurses, so continence clinical nurse consultants, and they can be very helpful in relation, if continence is an issue after stroke, in discussing issues and finding strategies to enable the person to have sex, even if they have a urinary indwelling catheter in place, and going through practical procedures with them and what to do with their urinary catheter, and coming up with a bit of a plan and some strategies with that as well. Addressing emotional and mood changes as well, and as I've said about taking a multidisciplinary approach and working with allied health staff, we have quite good clinical psychologists available and counsellors within our acute stroke services, and making sure that someone's connected in with a clinical psychologist after stroke is particularly helpful for a lot of people. And working with the speech pathologist if the individual has any aphasia that's causing any communication issues. And a lot of the time, after stroke, aphasia is very common, and around about a third of all stroke survivors will have some issues with speech. So developing strategies to deal with that in terms of provision of non-verbal cues, such as touch, can be quite helpful as well. And relationship counselling might be particularly useful for some couples or families, and finding new ways of doing things as well. And also talking with the medical practitioners around, and pharmacists as well, really thinking about medication interactions and side effects, and how that can affect sexual functioning as well. So just before I wrap up in my last sort of 5 minutes, I wanted to just provide a very short case study of a patient. And this is based on a patient who I have known previously. And I think this really, to me, highlights the importance of really good nursing assessment but also developing a care plan, management plan, and evaluation. But it also was an issue, and I think this is something within the acute stroke setting. We often provide a lot of really great care within our acute hospital setting, but also when someone returns home, our transitional care arrangements and follow-up sometimes isn't as great as it could be, and there's a lot of gaps in our transitional care and follow-up after stroke as well. So this gentleman it was a married gentleman who had an ischemic stroke and was discharged from hospital. And since returning home, he's experienced some relationship, what he describes as relationships problems with his wife. And when we unpacked this, he was living with his incontinence, and what she described, he was incontinent in the bed, and this had forced him to sleep on the sofa in the living area, and was a major factor in the contribution, a major contribution to his sort of mood and overall well-being, and was potentially one of causal factors in marital breakdown and also depression as well. He was also living with cardiovascular disease and hypertension and diabetes, but his incontinence was a key issue, and the unmanaged and unaddressed incontinence was a key issue contributing to his depression and his relationship problems as well. So he attended clinic, and he advised that his marriage was breaking down, and also described suicidal ideation. And I think a lot of this, to me, a lot of what he was describing really, to me, was highlighted the importance of a really good nursing assessment around incontinence, but also ongoing care in that transitional care sort of cross between acute services and living in the community as well, and making sure that patients are adequately followed up and have a really solid care plan, and also know where to go when they have issues that are related to their transitional care, and living with stroke after that very acute onset event as well, and making sure that there's support services around them and they can adequately access the support services, and these are relevant to them as well. So hopefully we'll have time to discuss that in the Q&A a bit more, but that's I'll wrap up there, and I'm happy to take some questions in the Q&A session at the end. So thank you very much.
Thank you very much, Dr. Ferguson, for sharing your excellent thoughts and experiences. If you have any questions, please don't hesitate to type in the chat box, and we will ask at the end of the presentation. So Dr. Ferguson, he has described about like stroke has not changed only the patient's physical health, but also emotional and sexual relationship with their partners. But sexuality is still a taboo. So the healthcare workers, we usually not talking about it unless the patients has opened up with us. It's just like in the case study. So we actually need the multidisciplinary approach in case of they need the help of the taking care of their problems, especially incontinence. So in the future, I think we need to discuss and plan more about the routine care, not just about the physical health, but also sexuality health. Thank you, Dr. Ferguson.
Thank you so much.
Thank you. So next, I would like to ask Dr. Usawadi to start, please.
Okay, you should see my PowerPoint, right?
Yes, that's
okay.
correct.
Hello. Actually, this evening, make sure the electrical line should be fine, because right now it's heavy rain outside of my house. Okay, so for today, I will talk about sexual health in surgical patients. As you already heard about the story about the stroke, and sexual health by Dr. Caleb, that is very touching because that is most of the patients. Sometimes when I take care of the patients, especially heart patients, they usually have some problem about their relationship in the family also. Yeah. So I will tell you like just a background of the sexual education in Thailand. The sexual education in Thailand, we start to learn sexual education in secondary school in Thailand. We try to teach early and like let's say like sometimes we a little bit difficult to learn in the school. Let's see some of the picture. This is from the class. The student reflect what they got from the class. Big teacher lecture by the backboard, while small students sit at their desks. And teacher lecture in front of while students are attentive sleep and just talk each other. So look like it's not effective class. So we have to think about that, like from the class and in healthcare setting in Thailand. Okay, let telling you like from my background, taking care of the heart patient, especially bypass graft and some of the chronic disease and valvular heart disease and some of the patients who have a surgery. So let's see, why do we need to understand about sexual health in surgical patients? It's kind of like a very difficult, right? To talk about sex if they're really sick. It's not true. We need to help them before they have problem. They are sick, but why we have to get them have another get problem in their family? So we have to think about and helping them in advance. So how many hours the healthcare providers spend with this problem? And do we know they have sexual problems such as sexual dysfunction as the complications after surgery? Like Dr. Caleb mentioned about that. And sexual dysfunctions may be the result of surgery, although it is not related at all with the surgery. They may never resume their sexual functions, such as sexual activity after surgery, such as after hysterectomy, and sometimes delay for resuming their sexual functions, such as anal surgery, more than 6 months to 1 year. And think about that. What gonna be happen in their family if they might get another partner? So it kind of like gonna be get problem in the relationship, right? So and from that, from some of my background in the clinic, like taking care the heart patients, and sometimes healthcare provider may give attention on the disease and their symptom. So sometimes the patients ask me, is it possible to talk about sex during meeting with the doctor, with the surgeon, because they have limited of time, right? So that's why I'm trying to think about like what we should do. And if you look at in the clinic in Thailand, in the hospital, only 1 or 2 sentences put it in the booklet to teach about sex. So it's not enough. They don't know how to handle that by themselves. Yeah. So that's why I'm just going with some of the research. This is all my student, my master students research. And the first research I'm doing with the ethnography and follow the bypass patients at home and have a time to talk with their couple. So we know a lot of problem, and they try to use the Thai herbs or some of the Viagra the medicine so by themselves. So that's why we have to think about how can we be the first person to give advice them instead of other people who have no knowledge at all. Okay, I will show you some of the research which I'm done. Factor related to sexual function in patients with valvular replacement surgery, that with my student, like, and factor associated with sexual function in women with urinary incontinence, and factor related with sexual function in patients after anal surgery, and factors associated with sexual functions in patients with transurethral ultrasound with prostate biopsy. You see, look like just a simple surgery, but some surgery is so big, like a valvular replacement. So, but how much hours we spend with prepare them for the sexual functions, which they need to have to cope with, right? So let's go. This is all the variable, right, which I mentioned to you, right, sexual function, but I will go with each variable. First, we thought the knowledge of sexual functions might affect or correlated with sexual function. Let's see how it's goes. And intimacy, how much they love each other. So this is another thing which we have to think about that. And functional status, how much they can do at home. And if they feel better, can walk, helping themselves, they should have sexual functions, right? And the sexual function should be better, right? But let's see, this is for the valvular replacement surgery. The knowledge of sexual function is not significant with the not related with sexual functions and intimacy, functional status, and age. Look at how the directions. Intimacy is negative, related negatively with the sexual functions, but functional status is related with the positively related with sexual functions, and is, right, negative related with the sexual function. So let's see, if they love each other, intimacy is getting high, right? But why sexual function is so low? Because they love each other. So they don't want to hurt, or they don't want to, they might hurt some wound, or they don't want to like just try to give support, right? So that's because they will get the knowledge from the healthcare provider. Like sometimes they need to get support. So from the knowledge of sexual function, so it's not significant for my study. So that after we going back to see the knowledge of sexual function, it's just told so little, like just 2 or 3 sentences that I just told you before. Yeah, let's go to see in the study with women with urinary incontinence and intimacy and severity of urinary incontinence. So from this variable, severity of urinary incontinence is not related, is related but not significant. But for the intimacy, this time is positive. And knowledge of sexual function is positive also. After we look at in the clinic for the woman with urinary incontinence, we know if this is for the woman, Thai woman, right? After they have problem with urinary incontinence, if in the family is really support each other, intimacy is very high, the sexual function is getting better very well. right? So they know how to handle, and they have the booklet teaching them how to do it when they have sex, even though they have problem with urinary incontinence. So they need to do something helping them before they having sex, right? And they get knowledge, sexual function. So they get the knowledge for helping them very well. So that's why this research mentioned about knowledge of sexual function, and they get better for the sexual functions. And the group of the patients after transrectal ultrasound with prostate biopsy. You know why I focus on this group? Because one time I look at in the newspaper, just the top head of the newspaper mentioned that sexual dysfunction after prostate biopsy. Look at the media too. If they have that word, and the patient gonna have a prostate biopsy, okay, they have to think about if they have a biopsy, they might have problem with the sex. How can we do? How can they gonna do? They might not stop having biopsy, right? So that's why we need to let them understand very clearly about what the problem and helping them in advance, not letting them coming to the hospital when they already have a cancer, right? So this time we want to know what we need to help them. So let's see, knowledge of sexual function still not significant, but the age, if they age very high, so the sexual function is not so good, right? It's just the just pathophysiology, but I can say that, but it is not, because when people have a sex or have a sexual function, they still get very old age. Sometimes people get very high. It depends on what the environment and what is their thought. So, but for my research mentioned about the age is a negative related with the sexual functions. But from this research, it doesn't show intimacy is not significant, because after I look at in the group, most of the patients are in the old age. So that's maybe they not stay with each other. Most of them stay separate or not stay together. Yeah. And another group, the patient after anal surgery. Intimacy is positive related with the sexual function, and knowledge sexual function is related with the sexual function but not significant. So let's see for population group, even though I have another group in cabbage also. Let's see, knowledge of sexual functions, only one study are related with sexual function. So just look at it, the knowledge which they give to the patient. So that's why we have to think about how much knowledge we should prepare for the patient. But at least intimacy, we need to think about in the patient who have like love each other, taking care of each other very well, and the group we need to teach them and support them, not just only not only the couple support each other during the surgery. So we need to prepare them before. Okay, so let's go to after I'm done the research for a while, and we try to, right now we create the program and helping the patients. So, but from the research, I can say sexual dysfunction is a common problem after surgery treatment. However, this issue has not been well aware of. These findings from research study may necessitate healthcare provider to be more considerate on this problem. Based on the findings, the researcher recommend that nurses and healthcare providers should assess sexual function of female and male patients. As Dr. Caleb mentioned about the like we need to assess sexual function also and provide appropriate knowledge about sexual functions for them. Not just only 1 or 2 sentences. We need to get the counseling and talking to them, and not just only talk only patient. Sometimes we need to talk with the couple also. Moreover, intimacy between the couples or partners should be enhanced to promote better sexual functions in these surgical patients. And another thing with the researcher, if you want to study, you need to find the measurement which really match with your study. If you measure for the woman, men, or the both, so you have to think about what kind of the measurement you should use it. I think John might mention about that too. And we need to develop the nursing role. I think this is very important. We need to assess sexual function, functional status, and intimacy, and provide guidance about sexual development, educate about sexual function and surgical and disease problem, and including the medicine. Sometimes the patient just come to talk to me, can I stop using some of the medicine? After I look at in the pamphlet, it show it affect to the sexual function. That's why I'm care, or maybe I'm concerned about my partner. So can we just stop for a week or something? So that we need to talk with the team or the surgeon and the doctor about how can we handle with that, especially some kind like a heart medicine, like a beta blocker or some kind of the medicine which might be effect to the sexual function. And counseling patients with other sexual functions, refer patient to specialists for treatment or therapy about sexual health problems. And I will answer if you have questions. But summary, I'm trying to let you to think about holism. Nursing care for the whole person. Sexual health is another need. We need to help other patients, our patients, to accomplish taking care of patients as the whole. Yeah. Okay. Thank you for today. And this is my email in case of you want to ask something. Yeah. Thank you.
Thank you very much, Dr. Savadi, for your excellent presentation. And Dr. Ferguson and Dr. Savadi have mentioned the same thing about the comprehensive approach in terms of the sexual health, because this is the gap area that we need to develop nursing roles in taking care about sexual health in patients. And surprisingly, the knowledge of sexual health is actually not related much about the sexual activity or sexual function of the patients. So we need to think about like how much knowledge should be provided to the patients and what kind of needs that the patients really need about their sexual health. Thank you very much, Dr. Savadi, and we will talk more about it at the Q&A session. Okay, next I would like to ask the last speaker, Dr. John Rihari, and could you please start?
Sure. Is my presentation up?
Not yet. Yeah, now it's working. Thank you.
Okay. Is it in presentation mode? It looks a bit different here. I've just updated my Zoom and I think it's done some things to my settings.
Yeah, could you please hit the presentation?
Sure.
Right now it's like sharing view. Oh, now it's great. Now it's great. Thank you.
It's good. Okay. Thank you everybody for inviting me. to talk tonight. I knew that I was going to be following some very good speakers talking about very specific things to do with sexual health in their specialties. So I thought what I would do is something a little bit more generic and just basically talk about why we get nurses or why the nurse's role is to educate patients, and also the difficult subject of bringing up sexual health with patients, and just some things that we might be able to do to make it a little bit easier for us as nurses and also for the patient. So it's actually a globally recognized issue that we need to consider in health. And the World Health Organization says from a macro level that it's a state of physical, emotional, mental and social well-being in relation to sexuality. And it's an essential part of overall health and well-being. And then I found a very good description from Van Luntz and Lahn, and it actually goes down to the middle level and talks about the ability to have a pleasurable sex life and to adapt and self-manage in the face of social, physical, and also emotional challenges, which we know that our patients are facing because they are sick. They're not well, otherwise they wouldn't be in our hospitals. And then down to the macro level. So what does it actually mean as far as nursing goes? And I think for a nurse, it means to provide patients with the necessary care to help them deal with these challenges and consequently contribute to their general well-being. And it's essential that we discuss sexual health with our patients for this reason. So what is the role of nurses in communication and education? Well, as part of our key role as registered nurses, it's one of our responsibilities. We're responsible for holistic care, which involves everything, of course, and returning our patients back to normal activities of daily living. We don't just educate our patients, we also educate families, we educate carers, and we also educate friends, because once they go home from that acute setting, if that's where we are, then it's up to those other people to help support them along the way during their recovery. Some discussions require temporary and even permanent lifestyle changes for patients. So these things that we actually present to them and start talking and opening up conversations can be quite challenging to them. Sometimes they will need to alter parts of their lifestyle that they absolutely love. And so having these conversations can sometimes be very stressful and anxiety provoking for our patients. But nurses are trusted professionals. We spend most of our time with patients, probably more than any other profession, on a day-to-day basis. And because of that, we have an ability to develop and bond and develop a strong trust with our patients. So that puts us in a prime position to be able to give this patient information. So just generally, we give patient information for many things. We talked about 2 tonight, but we also talk about disease prevention strategies. We give patient education on post-surgery and post-intervention care. We talk about chronic illness to patients, such as diabetes and heart failure, and how to live with those things, and what they can and can't do. We talk to patients and educate them about severe illness, such as when they develop cancer. And then we have a very difficult job sometimes in talking to patients and educating them around end of life and advanced care planning. So it is definitely part of a nurse's role to educate patients. So what about our patients? Well, when they're sick, quite often they're in a vulnerable position. They're out of their own environments. If they're in hospital, they're in an environment that is very alien to them. They're usually suffering an illness or injury, so they're not physically 100% or mentally 100% anyway. They sometimes feel depowered because we are making decisions for them. We have doctors making decisions around treatment options and diagnostics and procedures, and they have very little control other than saying yes or no. They want them or they don't. And that may lead our patients to be feeling quite anxious, feeling overwhelmed. And because of that, they're afraid to ask questions. So this is where nursing education is extremely important. So as we said, part of patient care is patient education. So we're generally comfortable as nurses discussing topics like surgical wound care, rehabilitation services, when to return to driving, exercise or work. But when it comes to sexual health, that can be a very uncomfortable topic, not just for the patients, but also for us as nurses, especially if we don't talk about those sort of things on a day-to-day basis ourselves. So some of the barriers that prevent us from effectively talking to patients about sexual health is embarrassment. Either we are embarrassed or we are afraid to embarrass our patients. We're uncomfortable with our own sexuality. It's not something sometimes people keep it very private. So therefore discussing somebody else's is extremely confronting. Sometimes we think our patients are too ill and not ready to be talking about sexual health. Sometimes we think we may be invading the patient's privacy. Sometimes we have a lack of guidelines or material resources. So, you know, you look around and there are a lot of resources on many things. Sexual health, unless you're in a sexual health clinic, you probably find that specialty related resources that you can actually use from day to day are quite scarce. There's also the cultural acceptance in the society that you live in that also plays a part. There are environmental factors. Sometimes you might be in busy, noisy wards. It's not an appropriate place to have a confidential discussion or give some information to your patient. And also short length of stay. If you're staying somewhere like if you're working somewhere like a day surgery center, you know, quite often you have so many things to do in such a short time that discussing sexual health with your patient may not be a priority. So there's some of the barriers that you might come across that are preventing us from actually performing our duties in regard to patient education. Also lack of knowledge and skills. So sometimes nurses may not have the knowledge or the skills to actually talk about sexual health, or are afraid because of that lack of knowledge that they may be asked a question that they can't answer. So yeah, not adequately trained in discussing these sexual concerns. So we just don't do it. Sometimes we just don't know how to start the conversation. And sometimes, as I said previously, it's just a lack of time and a lack of privacy, and we just don't think it's an appropriate environment to do it. So talking about sexual health with your patient is a very intimate topic. And as I mentioned before, sometimes the socio-cultural and religious backgrounds of people can have a big impact on whether those sort of things are discussed or not. In very liberal countries, it might be okay to talk to other people around their sexual behaviour and educate them on sexual health. But in more conservative countries, it might be something that is actual taboo and not spoken about. So nurses may be afraid of putting themselves or their patients in unpleasant situations when initiating those discussions. So having said that, what are some of the strategies that we may be able to use that can help us? So assess your own comfort. Get yourself comfortable with the fact that that's one of the topics that you're going to be talking about with your patient. Make your patient feel comfortable. So you can do that by establishing a rapport with them. Because you're going to be asking some pretty sensitive questions, I guess. So ask questions prior to initiating the topic of sexuality. So don't just go in there as that being your first and primary topic. And by doing that, just by asking questions, getting to know a little bit more about your patient, it will allow you to give better advice and also to tailor the information that you're giving to your patient. So avoid assumptions about your patient based on their age or their appearance or their marital status or any other factor. So not being judgmental is very important. If they can sense that we are judging them, they will clamp up and they will not ask questions, and it will not be a good use of our time, and it will be ineffective for patients to be able to get the information that they need. Try not to react overtly. I'm talking about conservative patients, but sometimes patients aren't, and they're very open about stuff. And they may tell us things that actually shock us. And so it's important that when they do open up around what they do sexually and what the questions they might want to ask us, is to just take it in our stride and go, okay, fine, and then try and answer the questions. Sometimes you might need to rephrase your questions or briefly explain why you're asking the question that you're asking, if the patient seems offended or doesn't understand what you're asking. So having said that, ensure that you both understand the terms that are being used. So, you know, as you're speaking to the patient, they may use terms that are probably not so medically orientated, but that's fine. So when we're talking to them, we can respond with those terms to them, so it relates very much to what they're talking about and the way that they think and understand things. Ask for correct pronouns or terminology, so we are addressing them correctly. And around delivering it, as I said before, there's no need to highlight sexual health as a standalone topic. So you don't need to go into their room and just go, I'm going to talk about sex today. So you can actually do that by adding it to things like physical exertion talks. You could say things like sex is usually a mild to moderate activity. So if you are finding once you're home, you're able to climb 2 flights of stairs without pain or without shortness of breath, then it's pretty much okay to resume your sexual activity. So by doing that, you've just lumped it into something that is overarched by the actual physical abilities of what they can and can't be doing at the time. Use open-ended questions to encourage discussion. So don't just say statements and then say thank you very much and walk away. Phrase things in a way that they feel that they are allowed to then ask some questions back. And that also provides more opportunity again to tailor what you're telling them to their own individual needs. So there's a couple of ways you can probably deliver the education around how you're going to set it out. You can do one-on-one talks with the patient, or you can, if you have a space in your ward and you have regular patient education sessions, you can round them up and you can do a workshop where, I guess, in that scenario, patients don't feel as intimidated because they're sitting in a group and you're talking to all of them. But I guess the disadvantages of that is if they do have individual questions, they might be quite reluctant to actually open up inside a group and talk about those questions. So you could even do a combination of those. You could do a group session and then say, oh, I'm going to come around individually to you later on to talk about any individual questions that you might have or might want to raise as something that I haven't discussed today. So it's up to you, I guess, and also the patient and the wards and the specialties you're in as to how well patients are and how ambulant they are, as to how you might be able to do that and what kind of environments you can teach in. So having said that, what kind of information should you be giving them? We'll keep it practical and keep it in language that they understand. You need to tell them about things like when they will be able to resume to normal sexual activity, things to avoid. Example, sexual activity after a heavy meal or consumption of alcohol. Talk about any possibility that they may have with experiencing sexual dysfunction, like we've talked about already in the previous presentation. But also where they can seek help and advice for that, because quite often we start in an acute setting, we start the process of patient education and then they go out into the community for rehabilitation or for follow-up, like Caleb mentioned. And then that's where they will need to feel comfortable in bringing those questions back, because they may not have them at the time that they're in that environment with us. Also about the effect that some of the new medications that they're on can have on their sexual function as well. And then always try and seek feedback and some clarification from them that they're understanding, and is there anything else that they want to know. So where can we find these resources? As I said, they can be quite scarce, depending if you're looking for something very I guess, specialty specific. Search engines are good, Google, but we know as registered nurses, we can't just take everything off Google. We need to actually have a look at it. We need to analyze it for its content and make sure it's from a reliable source before we use that information. Journals, well, absolutely perfect. They're already peer reviewed, most of them. And so that information is very accurate. And so we can use those as well to help get some information. And also professional bodies and organizations. Sometimes, for example, heart and stroke associations already have downloadable pamphlets, or they have information on their website around sexual activity with those kind of disease processes, but also government agencies as well. And I was also thinking, as the other two speakers were talking, generally there is a communicable disease centre located close by our acute centres. So you could go to those nurses and ask them how they approach patients, what kind of information, and you can even work together in helping to design something specifically for your unit or your ward or your specialty that you don't have already. So there's all those kind of resources you can actually draw in to make your own if you can't find anything suitable. So that's about it. So I guess the take-home messages are to make sure you're comfortable when you're talking to patients around sexual health. Build a rapport so your patient's comfortable with you coming in and talking about those things. Be relaxed, have a plan, know where you're going to be talking to the patient about this and how you're going to introduce it. Consider the cultural and gender appropriateness of even the nurses. So for example, a young female new graduate nurse may not feel comfortable talking to a 60-year-old male about sexual health. So you can use your colleagues, use your workmates in instances like that. Also in religion, where it's not appropriate for a male nurse, for example, to be talking to a female about sexual health. So yeah, use your team. That's part of your resources. Find out the patient's current level of knowledge so you don't go in there and start telling them about stuff they already know. As I said, use open-ended questions to encourage feedback for them and also allow you to be able to tailor and customize the information that you're giving them. Give them practical information that they will understand, and also allow for follow-up questions and give them referrals of where they can go once they're discharged for that kind of information. And that's it. Thank you.
Thank you. Thank you so much, Dr. John Rihari Thomas, for the brilliant presentation. And you gave us ideas how to approach to the patients in the real setting. And it is very important because nurses usually feel uncomfortable to talk about sex with the patients as well. And we need to think about the environment and also the cultures, and also what we need to talk with the patients, what do they need, and we also need to give them some resources when they want help, when they seek help and advice. Thank you very much for now. We're going to the Q&A section, and we have some questions already. I would like to ask the team to spotlight all of us, please. Okay, the first question is for Dr. Ferguson. The question is, patients with stroke are not always comfortable requesting information. What strategy would be beneficial to help staff engage with patients and their partners?
Thank you. I think the question, and as John has just mentioned, I think having the conversation in the first place is actually really important. And I think that it's something that we either don't do well or we don't do at all. And I'd probably say it's the latter, that we don't do it at all. And some of the audit data, as I mentioned, from the Stroke Foundation really highlights that gap that it's just not addressed. It's not addressed at all. It's not talked about because it's taboo. But also, I guess the time pressures, the chaotic nature of acute care might not also be the right setting to have those conversations. And, you know, as John was mentioning as well, that I think once patients go home and their readiness to learn is perhaps better, you know, they've adjusted to living with their stroke, their relationship might be quite different, and they feel ready to have a conversation. That might be in a, you know, very different care context as well. But I also wanted to flag, you know, our peak bodies like the Stroke Foundation in Australia, but also there are a number of peak bodies across the world, and I'm pretty sure the World Stroke Organization also has some resources, but our Stroke Foundation in Australia have fantastic patient-facing resources on this very subject. And I think in the format of information is important as well, with people who might have be vision impaired. So we have podcasts available for them, but also blogs from other stroke survivors, where they can engage and ask questions that they might not want to ask or seem silly to ask a healthcare professional. So they can ask other stroke survivors, and you know, this happened to me. What, you know, when did you start having sex after your stroke event? So I think sometimes that makes it a bit more comfortable for people as well. And you know, the value of peer support, particularly, you know, just having a fellow sort of stroke survivor that you can tap into and say, ask these sort of silly questions that you might be embarrassed or ashamed to ask someone as well. Yeah, so I think having the conversation in the first place is really important, and having something to guide that as well. So a resource, quite important as well. Thank you.
Thank you very much. Would you like to add more information or answer this question, Drs. John and Usawati?
I guess one of the tips that I gave was how to approach the conversation is to embed it into an overarching subject of physical activity. So sex is just part of a physical activity, the same as running or swimming or walking. So I guess an easy way and a more comfortable way to approach that is to say, I'm going to talk about the ability of you to be doing physical exercise and activities, which will include, you know, as I said, talk to them first, find out what they do. Maybe they cycle, so you can say, okay, this is when you'll know that you'll be able to cycle again. Do you have a partner? Because this is how the sexual activity will also work, and when you should be able to resume that as well. And so you can make it feel a little bit more comfortable just by having it part of something else rather than focusing directly on that. So
thank you. So I think usually patients misunderstand about they cannot have sex anymore, and sometimes they don't know when to start, and I think it's too sensitive to ask the questions to nurses sometimes. So it's I think it's the first step is need to start the conversation, right, with the patients. Okay, so so the second question for Dr. Usawati, regarding your research experience of sexual health in Thailand, how do researchers develop the intervention to manage sexual dysfunction considering cultural sensitivity issues? I think this question all of you can ask as well, because we have a different cultural context. Thank you.
So for this, intervention, it depends on the group of the patients. But if you focus on the urinary incontinence, that we need to get the support helping them, like let's say continuing care, not just only one time, because this is the symptom with gonna be take longer time, and so we need to help them and support them. And you know, sometimes the patient not tell the truth thing, so we need to be the trust person. If they trust us, so they open mind and talk to us, especially for we usually talk to the patient. Sometimes it's kind of like we need to talk with the couple, because if the male or female, and sometimes like the husband talk, oh, no problem at all, but the wife might have say something like why they feel emotions like not good mood, like a very like a bad mood all the time. So after we have a time to talk with each other, and look like the guy usually be the head of the family, like, and the role is changed after they cannot do the role of the head of the family. So that's why sometimes they reflect by bad mood. So sometimes we need to support them after we have time, after we let them talk with each other and try to release some of the depression and talk about what we can help. We can like stop some of the medicine, change the medicine, helping them, and they have some kind like a specialist to help them. So after that, they will feel get better. And especially the nurse have to have open the time for them, because you know, the doctor in Thailand, especially physicians, they have a very feel like just a short time to talk with the patients, and especially if they're really sick and they talk about that. Like for example, after they get recovered from some disease and they talk about the sex, look like that is like a prohibit. They don't want to talk about that. So they feel like I'm really sick and I can talk about sex with the doctor. It kind of might be not a good manner to do that. Yeah. So that's why I think the first thing, the nurse and the people, especially for the healthcare provider, need to open mind and have time for them.
Yeah, Dr. Ferguson, would you like to share with us?
I think that I was just reflecting on also sort of more broadly, not conversations directly related to sex, but also more around relationship changes with chronic disease and role changes and the care and caregiver, family caregiving responsibilities and changes that come with that. Feelings, you know, of being a burden or worrying, and just how the relationship between the person with the chronic disease and their caregiver or family member changes over time, and just the stress that can sometimes cause within the relationship. And I think that it's probably not well addressed in terms of making sure that they have the additional support and correct support, and communicating with the patient and their family member around these changes are normal, they're complicated, but there are support strategies available and also support services, particularly if someone needs a period of respite or some additional services at home. And sometimes caregivers can feel that this is a point of weakness for asking for something, or that the quality of these services, they're not very good, or they're of poor quality, or they're not suitable for them, because, you know, I don't need that. So I think how we approach that as nurses needs to be, you know, quite sensitive. But I think it goes to the point around communication, really, and making sure that at the right point in time, these services are offered, explained thoroughly about what they involve and how they can help. And having, just back to having those conversations, particularly important, making sure that people are feeling well supported, I think. And where they begin to run into problems is really that, you know, they've not had these types of conversations before.
Yeah, thank you. So I'd like to ask Dr. Rihari Thomas, what is difficult, in your opinion, what is difficult like for nurses in Australia to talk about sexual education and mention about sex with the patients? Because in Thailand, I think Dr. Savadi and I, we know it's quite sensitive. It's still like a taboo here in Thailand, and, you know, like conservative culture. Is this also difficult in Australia?
I think it is. I think we're probably a little bit more open to discussing it. We have some very good resources, as Caleb said, so it tends to be a little bit more open, but I still think it's very uncomfortable for nurses to talk about that with their patients, especially when they're approaching them to open up that conversation. I think it's just a general society thing. I think it could be global. Obviously, there are some countries, as I mentioned, that are probably a little bit more conservative than others, but I think generally we're not in an environment, we're not in a sexual health clinic where that is the main focus of why people are there. So they go there expecting to talk about that. They're actually sick for something else, and we're bringing this conversation into that environment. So, and these are cardiology nurses or stroke nurses or gastrosurgical nurses. They're not sexual health nurses. So it is talking about a topic that is a little bit left of center of what they do, but as we've seen tonight, it's very essential and it's very related to everything, really. I think it's difficult for everybody, but some people are just more okay with doing it themselves on a personal level. And I think the more that you do it, the hardest part is when you begin, but the more you do it, the more it then becomes routine. And then after a while, it's actually, you just blurt it out like you do when you're talking about running upstairs or whatever. It's just part of something that you say. So I think, my advice is just to have courage. And once you start doing it, you'll then get into a bit of a habit and you'll feel much more comfortable of doing that. And that will show to your patient as well. They'll see how relaxed you are about discussing it, and that will make them a little bit more relaxed as well. So.
Okay, so thank you very much. And I would like to ask this question to all of you, because we don't know like when we should give this information on sexual education to the patients. What is the best time to start this conversation to the patients?
I think it probably depends on what they're in hospital for and when their recovery and their discharge is likely to be. I know that, speaking from my own specialty in cardiology, we started talking about that as part of their discharge information. So it wasn't until they were kind of ready to go that we started bringing these topics up. And then obviously we would refer them to cardiac rehab, their GP, and then we'd say, if there's anything that happens down the track, please, go and talk to these people about it. So yeah, I think it's very specific. When you're talking about, as I said, day surgery, it's very difficult. You've got them for a few hours and then they go. So I guess that's very time dependent on, you need to do your time management and allow and factor in a little bit of time to be able to do that as well.
Yeah,
please, Dr. Sawadi.
Yeah, actually, for my research, like for the surgical patients, we need to start in advance. Let's say like start before having the surgery. We should have time to have some conversation, have know each others, and we gonna be the person who taking care you as a team and be part of the team with the surgeon. So. And after that, try to assess them how they do it in before having surgery, especially heart surgery. We need to know about before the surgery and after the surgery. And sometimes, the patient wait for the doctors or the surgeon to tell them to having sex. You can have sex now, so just do it. Like for example, they can walk. They can do activity at home, but they wait until the doctor tell them, because in the hospital they said the doctor tell them how to do it. So that's why sometimes we have to prepare in advance. We have some of the consulting, talk to them what they do at home, what do you regularly do it. And finally, after the surgery, in the rehabilitation or recovery period, So we should have the conversation and helping them before they using other method. You know, variety kind like a Thai herbs have they can buy it very easily. And when I visit them at home, they have some kind like a hot pot and boil it. That is for their health. And how can we know what is the component? And sometimes they have the component which is not good for their health. So we have to think about that before. And sometimes I got the herbs from home, and let's talk with the multidisciplinary team. Make sure what is it and what's going on with will be going on with the patient. And you know, some of the Viagra you can buy it in here. So sometimes patients just want to ask you, and if you say no, they will follow you. And sometimes they have no time to talk with the surgeon or the nurse. That's so they might try on it. So that is the problem. Yeah. So I think one of the important thing like that, make the patient trust you and talk and assess this in the clinic before they going back home and during the follow-up period. Yeah. Mm-hmm.
Yeah. So Dr. Ferguson, would you like to add more?
I think echoing what everyone's really said as well around, I think it's the approach as well, and when people are ready, and this is often quite difficult to tell, because as John mentioned, you know, and really before discharge is often important, and it's, you know, part of this discharge education to, you know, tick off the list. Oh, we've addressed this. It's a bit like driving. Everyone asks the question after a heart attack, MI, or you know, or you know, a stroke. When can I get back to driving? Yeah, but it's, you know, you put that question with the sex question, because it's like, oh, maybe not, no, maybe not right now. And sometimes if you say to the patient before they go home, so sex and driving, and then they're very, what? Why are you talking to me about this right now? This isn't, and you can sense this is a weird thing that they perceive this as very strange to be talking about right at this moment in time. This is really not what they're thinking about. And so I think, you know, coming back to clinic is an ideal opportunity. But I also, as we've mentioned as well, around some patients, that point around it, because the doctor's not said it's okay, I'm not going to do that. So this sort of fear and avoidance issue as well. So I think making sure that we really do address it, but it's a tricky one, because I think it's not the same for everyone. Yeah. So whenever it's ready for the individual. Yeah.
So it seems like we have to start first before they're coming to ask us. I think it seems like they need a permission, right? That when to start, like, they really want to know, but probably they don't know when to ask. And sometimes I think nurses, we don't really think about this topic that much, because we are thinking more about the physical health, but not about this sexual health. Okay. And I have one more question, because Dr. Savadi and Dr. Ferguson have mentioned about the patients with the urinary incontinence. And I have a question from the participant asking about, like, would you please share with us more how to give the sexual education with the patient who have the problem about urinary incontinence? And John, you can share with us too.
I think I work very closely with the continence clinical nurse consultant, and they have been an incredible resource. We have patients a lot with indwelling urinary catheters, and there's often this assumption, because I have the catheter, I can't have sex. And so I think myth busting that with the patient, just because you still have the urinary catheter doesn't mean that you can have sex. And then it's this like, oh, really? Like, so I think, and then really tapping into their expertise as well, and going through sort of procedurally how that might happen, having a bit of a strategy and making sure that they're very comfortable in this. I think the issues related to catheters in particular can be quite tricky. We have patients at home in the community that have all of their equipment, but still have issues with blockages and leakage and infection and so on. So I think really making sure that they're well educated and counselled on procedural aspects to living with the catheter, and where to go to for help with that as well. But I think once they've had a bit of practice and get more comfortable and confident with how things work, then it's part of normal life. And I think I think getting sort of almost this sort of training aspect worked out in the first instance, and I think there is a bit of sensitivity, I guess, and it goes back to John's sort of talk really around developing rapport with these patients as well, and getting that rapport to say there's no silly questions about this, and acknowledging that it is maybe a bit of a weird thing to talk about, that this is like they maybe feel a bit weird about it, but embracing this and really sort of working through that together to say, we can get through this. And I think that having that rapport is really, really important. And I think there's a lot of different, as I mentioned in my presentation as well, there's a lot of different aids, physical sort of aids as well for continence, but also medication related strategies as well, to support individuals to have a very healthy sex life as well. So I think embracing all of those different strategies and tapping into the expertise to have as good well-being as possible is really important.
Thank you. Dr. Sawadi?
Yeah, let's focus on women. Like if they have a problem with the incontinence, look like sometimes it look like a body image. They lost body image. So we usually teach them how to take care of themselves and think about try to empty the bladder if they want to have a sex, and talk to the partner, and they need to think about how to get rid of some smell. So that's why they try to have some, in Thailand, we have variety of like a flower smell, variety thing, make the environment just getting better. But you know what, as long as they love each other, they will overcome with this problem. But if they cannot continue and serving this problem, it kind of like a very hard, because as I working in the clinic for changing the catheter, like some patients have to take the catheter for Foley catheter for a long time. Sometimes they usually say, I have to be alone. So that's why we need to support them during they start having we put their Foley catheter just the first day. So we have to talk to them together, we have to support each other and helping during the way, because I thought all the equipment we give the patient, our health profession need to support them and don't think just, okay, the symptom is relief, so they need to get cope with themselves. It's kind of very hard for them. Yeah. And especially for the woman and body image. I'm saying for the male also. Yeah. But this is the way. Yeah. Mm-hmm. And I'm agree with Caleb when you mentioned about not think only sexual intercourse, but have to think about the sexual relationship. Sometimes if they just hug and just talk politely, love each other, just have a good relationship, that will help each other and they can pass the difficult time after they have a chronic disease. Yeah. Okay.
Thank you very much. John, would you like to share with us? You have any experience in taking care of the patients with the urinary incontinence?
I don't have any at all.
Okay, that's totally fine. But thank you very much, because like you know, like this is the first time for me too, talking about sexual education, because even though I'm working in the OBGYN department, we always, like, you know, have to talk about sexual education, like when to start, will they when they can have sex after they give birth or something like that. But you know, this is like a different topic, and yeah, and it's very important actually, because this is part of our nursing care. Is a holistic care, but we usually focus just only the physical health mostly. Okay, thank you very much for yeah.
May I add something? I'm going to tell John and Caleb, yesterday it's Valentine's Day, right? But tomorrow is going to be Religious Day, like John mentioned. I don't know why they pick up the date today, because it's between Valentine's Day and Religious Day, because tomorrow is a big religious day for the Buddhism in Thailand. Okay.
Yeah, that's quite odd. Yeah, but thank you very much for your wonderful presentations, for all the speakers. ขอบคุณค่ะ ขอบคุณค่ะ Before we leave tonight, I would like to ask all of you to follow us on Facebook. We have Facebook, we have Twitter, and we also have the YouTube channel. So we will upload the video of today on the YouTube channel as well. So please follow us and join us for the next webinar. In April, we're gonna have 5 more this year. So thank you very much, and thank you for joining us tonight, and have a great night, and see you again soon. Bye.
Thank you.
Thank you.
Bye.